for attending this evening's webinar session on effective antibiotic prescribing, shared decision making and delayed prescriptions. We hope that by the end of the session you will have identified quick and easy communication methods that will enhance your discussions and improve your shared decision making with patients, and also that you'll recognise when backup prescriptions are appropriate and take home some quick and easy tips on how to explain backup antibiotic prescriptions to patients. My name is Dr. Donna Leckie and I am head of the Primary Care and Interventions Unit at the UK Health Security Agency. Some of you may have known us as Public Health England previously. So before we go into anything, there's some important housekeeping information I want to share with you. So this is a live session and it is being recorded to be hosted on the Target website. So because of that, please remain on mute and please add any questions during the presentation to the chat. We'll be able to see those, and we will have a Q&A session in between each of the webinars. And just to let you know, it may seem a bit strange, but although this is one large webinar, we will be presenting it as two halves. So Linda, the presenter, will be presenting herself twice. And this is because we're going to split it in two halves and host it on the Target website as two separate webinars. Before we actually go into the webinar in detail, I wanted to highlight why we focus on antimicrobial stewardship in primary care. I'm sure much of this you already know, but there is much information out there about the threat and consequences of antimicrobial resistance. But just to put that into context a little bit, a UN report in 2019 highlighted that by 2050, AMR could kill 10 million people per year in its worst case scenario. So that's more than diabetes, the predicted numbers for diabetes and cancer combined. And this would also come at a cost of £66 trillion. So I think that's an absolutely staggering numbers there. And although this was 2019, we have come through the past 2 years where we see what a viral infection can do. Can you imagine if we had a bacterial infection and no antibiotics, what could possibly happen? So what does it mean for us? We know that 1 in 3 individuals in England take at least one course of antibiotics in a year, and the majority of these, around about 75%, according to the recent ESPIRE report, are prescribed in primary care. The good news is that in 2015, we saw the first fall in antibiotic use in general practice for some years, and this trend has continued. So I think we put out the concern and everybody has risen to the challenge. So one thing I do want to highlight is that we saw a significant decrease in 2020, but we believe that this is predominantly driven by reductions in primary care utilisation. So we need to view that figure with caution because it is unprecedented times. So what are we doing about it? Well, as I mentioned earlier, I lead the Primary Care and Interventions Unit, and our aim as a unit is to improve the management of infectious diseases. Sorry, I forgot to tell Linda to move the slide. Linda, I hope you're moving it.
I am.
Fabulous. Our aim as a unit is to improve the management of infectious diseases through evidence-based guidance, training and intervention development to support healthcare professionals. And one of the ways we achieve this aim is through the Target Antibiotics Programme. So Target stands for Treat Antibiotics Responsibly, Guidance, Education and Tools. As you may already know, it's a toolkit designed to support primary care clinicians to champion and implement antimicrobial stewardship activities. Target is led by the UK Health Security Agency in collaboration with the Royal College of General Practitioners. And the toolkit comprises, as you can see on the wheel, training materials, patient information leaflets, audits and action planning, quick reference prescribing and diagnostic guides, self-assessment checklist, and learning resources. For those of you who visit the website regularly, and I hope a lot of you do, you will notice a few changes. And this is because the team have spent the last few months streamlining the website to make it easier to use and also updating some of the resources. So one of those changes include the addition of the Discussing Antibiotics with Patients section. So if you can click, Linda. This section was developed in close collaboration with experts from Imperial College London, click again please, and the University of Oxford as part of a National Institute for Health Research funding stream. And we've got colleagues from both of these organisations here, or universities here on the panel session, and I'll introduce them in a second. The webinars tonight were developed that were developed are summaries of this section. So do please visit the website to find out more information. There's a lot more detailed information there on the website. Next slide, please. So just to quickly introduce you to the team for the sake of time, I'll just introduce everybody here. So you've met myself. Emily Cooper is project manager, the Target project manager, and Eowyn Sides is the Target research lead for UKHSA. And Camilla Stevenson is the project manager from the RCGP side of things. And just before I forget, because at the end we will forget, I just want to say a huge thank you to all three of you for coordinating and putting this together. It wouldn't have happened tonight without you. And then to quickly introduce the panel members. So Dr. Linda Strettle is a general practitioner and honorary senior clinical lecturer, and she will be delivering the presentations tonight. Dr. Steve Grenier is a general practitioner at White Ladies Practice in Bristol. Dr. Monzi MacLeod from Imperial College London. Monzi is a lead pharmacist for medication safety and anti-infectives research at Imperial and an honorary research fellow at the NIHR Health Protection Research Unit. And also Dr. Alexandra Borak, or Olu, from the University of Oxford. Olu is a researcher in health behaviour change. Her research focuses on optimising antibiotic use and implementation of antimicrobial stewardship interventions in primary care. And Olu is currently exploring the impact of COVID-19 on antibiotic prescribing and experiences in healthcare workers. So this is the agenda. I've just done the introduction. We'll do webinar part 1, which Linda will present very shortly, and there'll be an opportunity to ask questions after that. Then part 2, which Linda will present again, opportunity to ask questions to the panel after that as well. And then we will close promptly at 7:30, because I know it's late. You've all worked today and everybody wants to get home. So without further ado, I will pass you on to Linda.
Hello and good evening, everyone. And as Donna's greatly introduced, we thank you for coming and joining us this evening. I'm a GP partner in Rotherham, and I'm around 7 years after CCT, and I became involved with Target after I had a real problem at my previous practice with urine samples. Now, we're not going to deal with that today, but I did find that Target was a fantastic resource. It was really evidence-based, it was practical, and it was clinically useful. And there's a great team of people involved, and they kindly asked me to carry on a bit of the work with them, and that is what brings me here this evening. And so in this first part of the webinar, I'm going to talk about this question: I think I need an antibiotic, which is a common scenario we all come across. And it's about how to approach that consultation and putting the shared decision-making with the patient into practice. Thank you to all of you out there. I know you've probably all worked today and you've had a busy day, and we're trying our best, aren't we, in everything that we do at the moment, but you know, it's tough work out there. But this is perhaps easy ways to make your lives and the patient's lives a little bit better. And so what are the aims of this initial webinar? Well, we're going to try and identify quick and easy communication methods that will enhance your discussions and improve your shared decision-making with patients, and understand how the Target leaflets can help with that decision-making and support your consultation. So first of all, in order to understand how to communicate about antibiotics, it's important to understand why we prescribe in the first place. Research tells us that actually patients and clinicians tell us a similar story. As clinicians, we want to relieve a patient's symptoms. They're having many other things going on in their lives. We want them to feel better. And patients tell us the same. They want to relieve their symptoms too. As clinicians, we worry about complications. We worry about the patients who we do hear of who have sepsis, who, there's cases in the papers. We've heard of colleagues. We've had cases ourselves where patients have become more unwell, and equally, patients have that same worry too. They know of their mother, father, brother, or themselves who have ended up more unwell in the past with infections. Clinicians are influenced by previous experience, so we remember problem cases where things didn't go to plan. But we know that long-term giving antibiotics is an issue. But in the immediate situation of that consultation, we remember the tricky cases where perhaps antibiotics weren't given, or there was a delay and a problem was created. And similarly, patients are influenced by their previous experiences. We all know of the situations where the patient comes in going, "Doctor, I need an antibiotic for my sore throat." It always helps. But interestingly, research tells us that there's areas of misunderstanding between clinicians and patients too, and that often prescribers may overestimate the expectation for those antibiotics. And we have a feeling in the room with that patient that there is a demand for antibiotics, and we perceive that demand in the room. But actually, patient satisfaction is often linked to a careful and thorough examination, that their concerns have been addressed and noted, and that the patient has been given advice on symptom management. Rather than necessarily a prescription for antibiotics each time. And as clinicians, we may often perceive a demand for antibiotics when actually there isn't one there. The study by Caholtz looked at the tricky consultations that we face, and they often noted that failing to identify and satisfy an inconvincible patient led to an emotional drain. But actually, the antibiotic prescribing didn't always necessarily affect satisfaction with the consultation. We're already working so hard and having these consultations daily, and we're always thinking hard about what we do. We don't prescribe these antibiotics easily, we don't rush into them, but we're so busy at the moment and demand is through the roof, and sometimes it's a slight relief when we have an otitis media on our list or a sore throat in between all the multi-morbid patients that we're seeing every day. And we know that in a busy clinic, it's hard to miss out parts of the consultation or rush over explanation sections. But this can have a really big impact on whether patients are happy with our prescribing and our choices. But we do know that tweaking this consultation, so we're still doing the same things we do, but actually tweaking that consultation can have a big impact. And evidence shows that effective communication skills can increase patient satisfaction and understanding of our prescribing decisions. And if we actively have these discussions about antibiotics and using the leaflets I'm going to go through, that has actually been shown to have higher satisfaction with patients and enable the patient to manage their own infection. There's also been evidence that it reduces consultations in the future. So investing now can have future benefits, and prudent discussions about antibiotic prescribing reduces consultations. And finally, we reduce antibiotic prescribing by having these more detailed consultations and conversations. There's been examples here in the UK where in a UK GP practice, prescribing was reduced when the technique I'm going to go through in a minute was used. And I'm going to show you a way to approach this consultation that can be really effective. So the acronym I'm going to go through is something called CHESTS. And this is a specific tool that can be used for antibiotic consultations. And in a randomized controlled trial, it was shown to reduce the amount of prescribing of antibiotics in UK general practice. And it's a series of phrases that are used to reassure patients, improve understanding for the patients and satisfaction with the prescribing decisions. And it can be really helpful in those consultations where patients have an expectation of antibiotics. And to be honest, it's things we're already doing, but it's just including all of them. And it's being quite specific about how it's done. So firstly, concerns, specifically asking, what are you most worried about today? Now, we all have ways of doing this. We all have our ways of bringing out that patient concerns, picking up on the cues that they give us. And there's many ways of doing this, as I'm sure you already do. But it's just remembering every time to pick up on that question. And it may be that you normalize it. So I may say something like, people come to me and often are worried about this. Was that something you were thinking of today? Secondly, during the history and examination, a really important part that can help a lot is providing a commentary during the examination. I find that really useful. For example, if a child is there and I'm showing a parent what intercostal recession might look like and the fact that it's not there. Secondly, patients are now a bit more educated, I think, since COVID regarding monitoring temperatures, oxygen saturation. So showing them the screen of the temperature monitor, which has a green light on a lot of them these days. And secondly, putting the SATS probe on the finger and actually talking them through what the numbers mean can be really reassuring for that patient. Expectations, so asking the patient, what do you think I could most help you with today, or how do you feel about antibiotics can be useful. And research shows that actually a demanding patient often actually wants more of a reassurance that the infection's not gone deeper into the chest, rather than necessarily an antibiotic every time. Regarding symptoms, it's really useful actually to provide a specific explanation for the symptoms that they have. So the example here is that phlegm is a normal reaction to inflammation in the airways. Other things I consider mentioning is that a fever is actually the body's natural way of killing infection. Other things I might mention to patients is how lymph nodes, again, are the glands and the body's way of fighting off the infection. So explaining in a simple, understandable way why the symptoms are actually there. Timelines. Now, we often mention timelines and we may say things may be better in a few days, but actually being more specific about the timelines can really help a patient understand what will come next. The example given here is that a typical cough can last 3 to 4 weeks. I suppose my caveat to that would be that at 3 weeks, most patients, I'd be wanting them to come back to consider a chest x-ray for more serious pathology. But it is important to give that specific timeline, and I will give you more information about that later. Shortcomings of antibiotics are also really useful. So actually specifically mentioning the side effects that can occur and the frequency of those, so that patients can understand the negative impacts of antibiotics. Self-care advice, again, are positive actions that the patient can take. So not just, go away and drink some fluids, but actually take regular fluids at these intervals, particularly in children, giving specific advice about fluid intake, and in adults and children, paracetamol, ibuprofen, and the kind of frequency of those. And then finally, as we all do already, safety netting. But the leaflets that I'm going to go into later give some really clear, specific safety netting advice on the red flags that's really clear and easy to understand. And that helps the patient know when they should seek further advice. And the first 5 minutes of the consultation can be used to do all of this. And as I say, we're already doing it, but it's just doing it in a very specific, understandable way, which, as I say, in this randomized controlled trial has shown to improve and reduce antibiotic prescribing. And then the second part of this, so the timelines, shortcomings, self-care and safety netting, is covered in the patient leaflets, which I'll go through later. So why would it be useful to discuss a patient leaflet with a patient? Why is it useful to add that into the consultation? Well, actually, it's a really nice way to support the advice you've already given. And it's something for them to take away and look at later. We know that patient recall isn't always great of the safety net and advice. This gives it in a way the patient can reflect on later. It addresses their concerns. And again, I'll show that these leaflets in a moment. And it empowers the patient to self-manage, so it gives that self-management advice. It improves the patient recall, so it allows the patients to have a look back again at what you've mentioned. It improves satisfaction ratings, and it standardizes the advice. So if everybody is giving the same advice and everyone is using the leaflets, it really shows that this is the way that things are managed nationally, locally, and that perhaps that might prevent people from doctor shopping or moving around to different prescribers, because everyone is working in a similar manner. And how to discuss these leaflets? Well, actually, it's really important that these leaflets aren't just kind of a throwaway at the end of the consultation. It's good to personalize them, to make it relevant to that patient. And that also helps patients to feel that it's part of something that relates to them. It's not just something that's given as an extra at the end of a consultation. And where can you find these leaflets? Well, as Donna previously mentioned, the Target Antibiotic Toolkit is really useful and a great resource. And there's a whole section on there with all of these leaflets on there. Other places that they're available on Accurix text messaging. If you put Target in the search bar, it comes up with the respiratory tract infection leaflets and also the UTI leaflets. So they're easily accessible and sendable to a patient. And secondly, if you do have Arden's systems, they're also integrated into those systems as well. So that, again, will link directly into that patient. And this is an example of one of the leaflets that are available. So this is the Treating the Respiratory Tract Infection leaflet. And as you can see, this links in nicely to the CHESS acronym. So We've got the timelines here for most of the simple infections, the self-care methods that people can use, the safety net and advice of when to seek further advice. The side effects of antibiotics are mentioned at the bottom. And as I mentioned earlier, you can tick the different boxes and you can put specific details relevant to that patient. Here's the urinary tract infection leaflet. And again, it has the symptoms of a UTI, the timelines that you'd expect for UTIs, the self-care that is available that the patient can do themselves, the side effects of antibiotics and concerns with antibiotic use, and the safety net and advice for when to seek further advice. And these are also available in HTML. As I mentioned, Accurate, you can send these information leaflets through that as well. And there's many of these leaflets out there. So there's a simple one about how I can manage common infections that's available. The respiratory tract infection leaflet I've just mentioned. A simple self-care steps for respiratory tract infection leaflet, the UTI leaflet. And finally, a really useful one I find is the UTI leaflet for older adults and carers. Slightly simpler, it mentions easy ways to ensure that patients are improving and how to kind of improve the hydration, so looking at the urine colour. And it's just a really nice option. Finally, thank you for all that you're doing. I find this a really useful thing to do. And I hope this is something that you can incorporate into your consultations to make those consultations a little bit easier and hopefully improve all of our prescribing. Thank you. I'm now going to open it up to the panel for further discussion.
Thank you so much for that, Linda. That was really, really lovely, well presented. We have a few questions that we got asked in the chat and some questions that had been sent to us earlier. One of the questions came from Miley. Can you share information? Can we share the information with all of you so you can share the information with your colleagues? And the short answer to that is yes. The RCGP will be sending out an evaluation questionnaire after this, which will have links, which will contain the slides and also have links to the Target website, which will contain all of the information on there and all of the patient information leaflets. Another question we got is from Naomi, are the Target leaflets available in languages other than English? I'm going to actually ask Emily to answer this.
Sure, yes. So if you go on the Target Toolkit into the leaflets to share with patient section, we have them translated in the majority of kind of common other languages that are spoken in England. So you should be able to access those translations and download them in PDF.
Fabulous. Linda, you talked about using the CHESTS acronym. Can you give an example of what type of questions you yourself have asked or have used in practice that relate to CHESTS?
Absolutely. So as I said in the presentation, for the concerns, I would try and normalize the kind of presentation. So I'd say to a patient, often people worry about pneumonia, or they worry that that this is going to get worse, or they've heard of another person getting unwell. Is that something that would concern you? You know, what are your other agendas? Have you Googled something? As I mentioned on the history exam, the commentary, I tend to use it as an education thing for parents often. So as I'm looking for respiratory distress, say, in a child, I'll mention that I can't see that and what it would look like. Using the thermometer with the colour screen, helping a parent see or an adult see the actual outcome of a test or check I'm doing. In the symptom section, as I say, I would look at the lymph nodes and explain that that's the body's natural way of fighting off an infection. And then coming on to the last part, as I mentioned, I'd use the leaflets to talk through all of the kind of self-care and safety netting that a patient can do. I also often have a slightly separate safety netting tool that I use. So the Sepsis Trust has got some really great information on there with telephone triage and sepsis kind of signs. And I've put that into a text message with sepsis signs to look for. So I sometimes send that alongside this as well. And something I found really useful is that I compare antimicrobial resistance to COVID, and I think that really hits home. As you mentioned in the introduction, we have all been completely shaken by COVID and the impact a virus has had on our lives. And I do say to patients that, what if in the future we have bacterial infections that we can't treat? Can you imagine how that would be? We all know how bad COVID's been. What happens when antibiotics don't work? And you do get a look of realization on patients' faces when you say that to them. And I find that's a very effective way of really getting across my concerns about antimicrobial resistance. And actually, I mentioned that to colleagues too. And then the penny drops often of, oh, crikey. And I have to say, even this week, I've had many letters from the hospital with people with multi-resistant bacteria in various samples. It's out there. So we've all got to play our role.
Yeah, no, that's true. I want to hand over to Steve. Steve, we know there's 10-minute consultations. That's limited time. How do you cover all of this in your 10-minute consults?
Thanks, Donna. I mean, of course, these are consultations that we're trying to catch up. We try to use as a catch-up consultation. So there is the risk to go very quickly. I think definitely the worries and expectations question early on in the consultation is really useful. Because if someone says, well, they might say, I just want you to check that I don't need an antibiotic. It's quite helpful because they're saying, I don't specifically want one, but I just want to have that reassurance, and that sort of can take your path down one particular discussion pathway. Whereas if someone's saying, I need antibiotics, I usually need antibiotics in this situation, then the discussion is going to be quite different. And I think, and then I try to use that as well to say, look, I'm prepared to prescribe antibiotics if you really feel you need them, but let's have a think about this together. So you might just then take away that their need to maybe to sort of push you to prescribe an antibiotic. Say, look, I'll give one if you really need it, but let's have a look at the pros and cons, and then have that discussion as adults around these. So I think early on, knowing what the patient wants is really critical to doing it quickly. And then, of course, having the leaflet and all the other information available makes it so efficient at going through the self-care and the safety netting. Of course, the self-care bit as well, sometimes you've got that out of the history. What are you doing at the moment to help? And then you say, well, actually, you're doing all the right things. You don't need to go through that again because they've already told you they're doing, the fluids and the paracetamol. And then you're going to say, I understand that it's not getting better and it's frustrating, but still, you're doing the right thing. Keep going.
Okay. Which is really what CHEST covers all of that. One last question that I want to put across to the researchers for the sake of time is, Monse, Ola, you said, that the evaluation was successful. You guys developed this at Imperial in Oxford, and you evaluated it. So what did the GPs who were part of the trial say about using it?
Thanks, Donna. So yes, there was quite a lot of co-production development with GPs and patients actually to develop the resources. And when we implemented it, there were some barriers to trying to get people to engage with information, which is actually hosted on a separate website. But for those who did manage to engage with it, they did find it very useful. In terms of the content, it made sense to them. It was something that they found actually, as Linda said, it was about tweaking what they're already doing. The leaflets in particular, some of them, they used them by having them in all their clinical rooms, having them on the desk, so it was ready to hand. So on a face-to-face consultation, actually, there were some really practical ways in which people implemented and used it. And what we did was we offered the resources in a way that supported them to use it as they want in their general practice. So people could adapt it the way that was most useful for them. We also had some posters and things and shortcuts in which you can aid memoirs that they could put up in their clinics as well, just to help them, at that time as well. And for the patients, I think it meant that having this information to hand also give them something to show. And, I think we've got some really lovely quotes in one of our papers where when we did the interviews with the GPs, they said, actually, it's having something you can show. It's not just me spouting hot air. It's actually people having a look at this. There's evidence behind it. And something that they can hold reassures the patient. So there is a lot of support there to actually help reassure the patient in those consultations by having these materials and these conversations.
Brilliant. I know I said that was going to be the last question, but I've got a really good question here from Ewan that I'm going to put to everybody. I think we've got time. Can you share your experience and how your consultation has changed from predominantly face-to-face to a telephone consultation? So I'll put that to Steve and Linda. Any of you want to take that one?
How the consultation around antibiotic use has changed? I mean, I don't know if it has a lot, because I mean, just say you're doing you're seeing some. I mean, speaking to someone with a sore throat, for example, I'd still use fever pain, for example, to do an assessment and discuss things there. I think for respiratory consultations, I suppose so respiratory is difficult because I think you especially in an older person with more clinical vulnerability. It's difficult always not to prescribe an antibiotic. Someone's got COPD, for example, and maybe got an exacerbation. And these are patients we speak to every day. And what do you do in that situation? I think it's harder. You maybe have a lower threshold for using, or sometimes you just got to bring them in, and have a look at them. Of course, more patients do have SATS monitors and other equipment, so you can get more information. I mean, we use the leaflets in the same sort of way we got them on an AccuRx system, so it makes it very easy to give the safety netting leaflet. So that maybe is another time-saving thing. Yeah, I'm not sure if I've answered that well, but.
I think I'd just add to that I've actually found it's helped me do this better, because if you're on the telephone, you can have the evidence in front of you while you're on the phone. So actually, I pull up the Target kind of toolkit and the UTI flowchart, and Ardens, if you have it, if you do the Ardens template for UTI, it maps to Target. So actually you can tick off the number of symptoms as to whether it fits the prescribing guidance or whether it's delayed or immediate. So actually you can do better with remote consulting sometimes for some of this stuff. With fever, pain and sore throats, I have a preset AccuRx text with a YouTube video of how to do a photo of your throat, which I send to patients before the consultation. So actually then you can see the throat, and then you can get most of the information for a sore throat over a telephone consultation. So actually when you call them, it's very quick. Also, there's recently a new Florey for UTI, so you can send that before the consultation, and again that maps through to the Target information. So actually in some ways remote consulting for simple infections is really efficient, and I think more evidence-based and more guideline focused. I think I would probably agree with Steve that in complex patients some of this doesn't necessarily apply, because in those complex patients, the risks and comorbidities are in a different kind of level. And a lot of this stuff with Target is potentially looking at the high volume prescribing for simpler infections in those kind of contexts, but lots of good things you can do.
And I can just really quickly add that having interviewed GPs about their experience of COVID and consulting remotely for acute infections, I think that I've heard the same as Linda and Steve were just saying. The importance of those communication skills is even more profound in remote consultations, because it's so important to reassure the patients and provide so good safety netting. So those tweaks and those examples that you've just heard about, I think are still relevant for remote consultations, if not even more important.
Fabulous, thank you, Ola. I think, sorry, I've just missed the question. I think that hopefully will answer your question. Was it So Mo Hyun, I think, made a comment about it being a lot more challenging to decline a patient request for antibiotics and telephone consultation. So I hope that shared learning will help you with that. For the sake of time, I'm going to pass over to Linda to deliver the second webinar. There's a lot of questions in the chat about delayed prescribing. Hopefully a lot of those will be answered as part of the presentation. And I've also been told by Camilla that all of these questions will be captured in a Zoom chat. So if we can't answer tonight because of time, we will get back to you with any responses. So do definitely keep those questions coming.